So now let's start our lecture time. And I want to welcome Dr. Sario Koichi, the chairman of the board of Japanese Association of Endoscopic Spine Surgery from the University of Tokushima, Japan, to give this first topic, transforaminal full endoscopic decompression surgery under local anesthesia, awake and aware condition. Dr. Sairo Koichi.
Hello, everybody. Can you hear me?
Yes, perfectly.
How
Welcome.
about slide? Slide okay?
Yeah, slides are perfect.
Thank you so much. My name is Koichi Sairo from Japan. And although this is a UBE meeting, but I was invited to talk something about the single portal surgery, especially for decompression surgery under the local anesthesia. So for the first talk is not the UBE, but please listen to me. Today's talk is surgery under the local anesthesia, single portal. This is my COI. I have a donated department by Senko Medical and MiPro. And also I'm a consultant for both Philippines and Rio, Japan. Today's my talk is a transcambient approach and transforaminal approach, not the interlaminar approach, because this approach is possible to perform under the local anesthesia. So I like this. Since my technique is transcambient, transforaminal, you know, there are three types in lumbar spinal canal stenosis: foraminal stenosis, lateral recess stenosis, and central stenosis. So I started to perform decompression from foraminal to central. Because my technique is transcambient, so foraminal stenosis is easiest. Then to a lateral recess decompression, and finally central canal decompression. So all of those techniques is possible under the local anesthesia. Maybe most of you know that Japan has a highly aged country. So a lot of aged patients in my country, and those patients has a poor general condition. So many patients is not allowed a general anesthesia. So this technique is very important. This is foraminal stenosis. I checked in the literature. Foraminotomy was first reported from Korea in 2003. And I started in 2015 using high-speed drill. Typical foraminal stenosis is right here. And SAP is got hypertrophied and pushes the exiting nerve root. Then after foraminotomy, look at this. The narrow foramen got bigger and exiting nerve is loosened and decompression is finished. It is possible under the local anesthesia. What's the secret for successful full endoscopic decompression? And I asked Tony Young in 2018, and he said, bone is my friend. Bone is your friend. Always at the beginning of the surgery, please look for the bone. This is a secret for a successful full endoscopic surgery. This is an explanation of foraminoplasty endoscopic one by one. First of all, placement of a cannula on the facet bone right here, and identification of the SAP right here. Then SAP resection. So after that, we can see the hypertrophied ligament flavum on the exiting nerve and remove it. And finally, we can confirm that exiting nerve is decompressed. I can show you one case. This gentleman has a slight local scoliosis plus foraminal stenosis here, the right side. Left side, it's big. So right leg pain. But his general condition is not good to have a general anesthesia. So I did it under the local anesthesia. See this. It pushes exiting nerve here and I remove it right here. It got bigger. Usually, decompression is successful. You can see the decompressed exit nerve root is beating, pulsation. So good decompression means good pulsation. This is a typical final view of the foraminectomy. This case is a professional baseball player. He's a southpaw, left-handed pitcher. He has been suffering from right buttock pain for 5 years, increasing the pain year by year. And finally, he visited me. You can see here, most of the surgeons he saw said that the spinal canal is okay, but he has a symptom, the right buttock pain. And I saw this. Maybe the fibrous canal is, foramen is narrow. So I injected dye on the L5 nerve root, and you can see here the nerve running right here, transversus. See, so something is pushing up the L5 nerve root. So I think this is SAP of S1. It pushes up, causing low back pain and right buttock pain. I injected the lidocaine on the right L5. Disappears. Since he is a professional athlete, this minimally invasive surgery is very good because the muscle damage is very minimum. And I did it for him. You can see here, S1 SAP pushes up the exit nerve here, and I shaved it. From the next season, he played without no pain, very well, for 3 years, and retired the last season off. This is a take-home message number 1. Transforaminal full endoscopic lumbar foraminectomy would be a best option for foraminal stenosis, but I checked my case and the clinical outcome is not good when degenerative scoliosis is combined. Second target is lateral recess stenosis. You can see here the recess, the facet spur pushes traversing nerve here, L5 nerve root here. So I imagine if we can drill the part, ventral half of the facet, that decompression is possible. So I imagined, so I started. First, I did it to a cadaveric spine. This is cadaver, not a patient. And you can see here, the narrow foramen completely opened up. And you can see through into the spinal canal, no more lateral recess stenosis anymore. And we confirmed that we can do it. Then I did it. Once again, I can show you the ventral facetectomy one by one. Placement of the cannula on the facet bone. Then SAP is identified. This time we need to remove complete rejection of the SAP. Then I did a IAP partial rejection. Then you can see the thick ligament flavum on the traversing nerve. And we remove it. And finally, we can confirm the decompressed traversing nerve. It is possible under the local anesthesia. Now I drilling this is a pedicle, and this is the SAP. And using Kelson longeos, decompress it. Finally, traversing nerve is appeared, showing a pulsation, no more compression anymore. This time again, the secret word is bone is your friend. And this is a case of the 4-5 lateral recess stenosis here. Is here. L5 is impinged and showing a strong right leg pain. She could just 3 minutes the walking. Look at this. Yes, I drilled the ventral half of the facet bone and decompressed L5 nerve root under the local anesthesia. Next case is a dentist, dental doctor. You can see here central disc bulging and also lateral recess, bilateral stenosis, and he had a bilateral leg pain. Since he is a dentist, he's working using my chair, and he said he need to return to job as soon as possible. So he asked me to do something under the local anesthesia for a quick return. And I did bilateral lateral recess decompression right here and here. You can see here, open up the foramen. And immediately after the surgery, no more leg pain anymore. And he's a dental doctor. He returned to work just 5 days after the surgery. This is a minimally invasive endoscopic surgery. How about this? He is a 65 years old male. L4 nerve root impingement here, and L5 nerve root impingement here. And he has a history twice of MED and MEL, interlaminar surgery twice. Okay, I did it L4, L5 nerve root block simultaneously and no more leg pain. So the pathology is 2 nerve root impingement at a single level, right here and here. What's option? I think gold standard in the world is facetectomy and fusion. But I did it here, single portal endoscopic ventral facetectomy, as well as a foraminoplasty. You can see here, L4 nerve root here and got bigger, normal compression, and L5 nerve root impingement here and here. So 2 nerve root was totally decompressed. So I'd like to say we can be beyond the gold standard. Final topics is central canal stenosis. It's okay. This is a 90 years old man. 90. General condition is poor. You can see here that the recess stenosis with HLP. 90 years old. And I did it under the local anesthesia and decompression here and here. No more pain anymore. This is L5, not good. Nothing is pushing L5. He's immediately after the surgery, he's okay. Okay, transforaminal full endoscopic ventral facetectomy. I think basically it's good, but if there is a spondylolisthesis, clinical outcome is not good. If slip is there, I perform the full endoscopic transcambing fusion. We call KRIF right here. Small skin incision, we can insert a cage. So this is an option for instability. There are my 2 great mentors, Tony Yang and Professor Akira Dezawa. And the final topic is central canal decompression. I named lumbar undercutting laminectomy. First of all, total SAP there, and IAP is also decompressed. Then remove the yellow ligament. This is a surgery for central stenosis under the local anesthesia. This patient is 72 years old female, both leg pain at L3-4, but foot drop there. So this means Cauda equina syndrome. So I recommend her central decompression under the general anesthesia, interlaminar decompression. However, she had a severe pulmonary dysfunction, so no general anesthesia is allowed. So I did it bilateral side, lumbar undercutting laminectomy right here and here, and remove it, the yellow ligament. And 3 after surgery, no more pain, no more palsy. This is the final view. You can see here from posterolateral view, but you can see here dura mater and pulsation and nerve root is here, and epidural fat here. So this is the final view of undercutting laminectomy. This is a three-dimensional CT scan after surgery. Although the big decompression here, but from posterior view, I didn't touch the facet bone right here, the posterior aspect. So almost 50% of the facet contact area is still exist. No instability happened. And I can show the final case. Here, severe pulmonary dysfunction here. You can see here, no general anesthesia. But she has a strong pain. L4 shifted forward, but the disc space is completely collapsed. Severe stenosis, but stable slippage, no instability, just a slippage and stable. But severe muscle weakness and no more general anesthesia. What's the plan? Severe central stenosis with stable slippage, caudal syndrome, no general anesthesia. For such case, I did from a posterolateral approach. This is SAP right here, and I removed it. And this is IAP. This is yellow ligamentum flavum, and IAP removed undercutting laminectomy. Thick ligamentum flavum is here. And I drilled completely. This is a thick ligamentum flavum. You can see here, L5 nerve root plus dura mater, and removed it. And finally, central is decompressed. So here, this is my plan, the dot line here, and remove that space, and also remove the yellow ligamentum flavum. See here. And also, from right side, compression exists. But interestingly, after surgery, both leg pain disappears. And she's okay. She's aged patient, poor general anesthesia, no pain. He's very happy now. So this is my final take-home message. Full endoscopic lumbar undercutting laminectomy. Surgical indication is central canal stenosis for the aged population with poor general anesthesia who are not allowed general anesthesia. If someone is possible to do a surgery under the general anesthesia, I do from interlaminar approach and take it out all ligamentum flavum. This is just in case for poor general anesthesia, poor general conditions. This is my take-home message, and transforaminal full endoscopic decompression under local anesthesia is a cutting-edge technique, and it can make the future gold standard. Thank you very much.
Thank you, Dr. Koichi, for this very nice presentation and local anesthesia. And we have one question from Dr. Arshad Parekh. And what complications did you encounter in transforaminal endoscopy decompression?
Okay, the common is exiting nerve root irritation. Since I'm doing this surgery under the local anesthesia, exiting nerve root injury is very rare. So nerve root irritation is number one. And the other ones, palsy is not so much. I didn't encounter dural tear or nerve root tear. So only concern is exiting nerve root irritation.
Thanks a lot. So for the other questions, the panelists can send their question, and we will group them together at the end to make a complete discussion. Thank you again. So we now go for the next speaker, Dr. Pang Yung, and Dr. Pang Yung General Hospital from Singapore. And his topic is versatility of unilateral biportal endoscopy in lumbar spine. Welcome.
Good afternoon, everyone. Can you all see my slides?
Yes.
Greetings, I'm Dr. Pang Hong Wu. I would like to thank the French Endoscopic Spine Surgery Society and ISUBE for the opportunity to speak on my topic of versatility of UBE in lumbar spine. This is my acknowledgement. I learned most of my Uniportal and Biportal skill from South Korea and my conflict of interest. Just a brief introduction. I'm a consultant orthopedic spine surgeon practicing in Jurong Health, part of a National University Health System, Singapore. I take care of about 12% of Singapore's population, and my subspecialty interest is endoscopic spine surgery. I practice a hybrid uniportal and biportal surgery. 60% of my practice is uniportal and 40% is biportal. Ranges from stenosis, decompression, fusion, discectomy, as well as cervical and thoracic cases. So there's a modern development of UBE as the floating technique has been there for the past about 15 to 20 years. There are different terminology in the literature. UBE as unilateral biportal endoscopy started being named by the neurosurgeon in South Korea. And several papers are also have a similar technique, which is called biportal endoscopic spine surgery. They call it BESS. They are developed from the orthopedic surgeon in South Korea. I think the key difference is the use of osteotome. I think in the best way of doing biportal, they use a bit more osteotome than the UBE. So Dr. Soliman also named it as irritation endoscopic decompression laminectomy, and they published in Spine Journal. What I like about biportal is that it is a very versatile technique, and you can basically stand in the same similar position of left hand holding, if you are right-handed dominant, left hand holding viewing ports and right hand holding various working instruments such as kerrison, drill, osteotome, etc. And you can stand on different parts of the anatomy and perform effective surgeries. It is essentially a floating technique. The benefits to the patient is enormous. Irrigation surgery decreased the infection rate tremendously. Having a panoramic view as a floating technique shows a very familiar anatomy that we show in our microscopic surgery. And it has a less limitation of working space because we create the working space that we required. We have a freely scoping and handling of instruments, and have a similar highly magnified view of uniportal surgery. It can be 30 to 40 times, such that it can be have an easier differentiation of structures. And at the same time, you can use ordinary similar spine instruments with minor modifications to open surgery, and hence probably can flatten the learning curve of endoscopy. You also benefit to the surgeons. We have the training, especially in orthopedic, in arthroscopy, just like Professor Loeck mentioned, is similar to acromioplasty in shoulder scope. And in neurosurgeon, they do transphenoidal scopic pituitary resection. We maintain the upright posture is probably better for us in terms of spine health, especially cervical spine health. It provides ergonomic visualization. It can be enhanced by, as we get older, you can see clearly, you can increase the TV size and have a better 3D, 4D level of high definition TV. We can engage assistants who can retract, and you can see from Professor Zhang and Dr. Song's assistant, they did perfect retraction and make surgery so seamlessly easy to do. With the familiarity of instruments, make us less anxious when doing this surgery. There are some weak points. I think, as you can see, we tend to might have difficulty in triangulation, and sometimes a red screen basically can't see what's in front of us due to soft tissue bleeding. With more experience, this blurring of vision is getting less common. We know where the bleeding spots are, tend to be soft tissue and muscle bleeding. We know how to deal with the epidural foraminal bleeding, and bones as well as other radiofrequency company provides good solutions to these bleeding spots. One important aspect in difference between uniportal and biportal is a very careful management of outflow by having the working portal to be sufficiently open to let water to be coming out. In uniportal surgery, there's an inflow and outflow channel, so that is taken care of. But in biportal, we need to make a conscious effort to keep the outflow going. Why do we need minimally invasive surgery when traditional open surgery yield good clinical results? Now, as we know, COVID-19 is the new normal. The situation is evolving. There are periods of time, especially in my country as well, where elective cases which require inpatient admission will be cancelled. So day surgery ambulatory procedure are allowed to proceed. And I find that in my own experience that we converted both uniportal and biportal endoscopic surgeries to ambulatory spine surgery where they are mainly staying less than 23 hours, and we are allowed to proceed and clear our elective workload. So in this new normal, we need to conserve hospital beds and also conserve the ICU as well as high dependency wards. So it is kind of what I wrote up as it has shifted from patients' benefits to public interest to perform minimally invasive surgery. And as you can see from my patients, the post-op care is pretty straightforward. This is about 4 hours after surgery. After I finished my second case, I went to visit the patient, and they are already ambulatory, walking, shown to be by my physiotherapist, and ready for discharge. And I've seen another patient taking selfie as I walk towards him. No complex protocol on blood transfusion, blood taking, wound check during these first 2 weeks of post-operation. This is another patient. This patient have undergone cervical endoscopic decompression and discectomy. This patient, I did it in uniportal. I find that it's similar result in biportal surgery. And a few hours later, you can see them being cheerful and already ambulating. And this 2 weeks later, and so the wound has healed, and she's still maintaining very good function and has gone back to work. So we can achieve very short hospital stay in open spine decompression and fusion, and it has literature has shown several ERAS protocol that requires somewhat quite complex protocol from the pre-hospital phase to a post-discharge phase. In UBE, I find you just need to have a physio and pre-op counseling for same-day discharge. In post-op, I don't personally use any drains, so those teachers mobilize them on the same day for decompression, and I mobilize them for the next day for fusion, and most of my cases can go home within 23 hours. There's not much need to inspect 1 cm wounds, so I do not need to wound inspect, and I tend to not remove the dressing until 2 weeks. So far, touch wood, no wound infection, and I now has moved on and do not use any stitches on the superficial skin. I use this style of skin closure device. We call it skin close. Is imported by us to actually close the skin without stitches. And in my own personal early series, I find that both uniportal and biportal, in terms of wound and conditions treated, have quite comparable good and comparable clinical outcomes. And we are gaining popularity in terms of both the uniportal and biportal endoscopic spine surgery, and people are in the spine community realize that it is important to provide minimally invasive surgery, and increasingly in multiple spine forum, we have endoscopic spine surgery occupy a session, as we can see here in the recent global spine, also held by French. Thanks for their enthusiasm in endoscopic surgery. AO Spine also wrote up a consensus paper to basically streamline the nomenclature, and UBE is listed as shown here. So what are the main differences in biportal and uniportal surgery? Being an academic cluster for advancement of surgical technique, academic results, research, I do both surgery. Personally, I find that they are pretty similar in terms of clinical results. And I published them in several papers showing the differences in the Uniportal and also raising up the challenges in the learning curve. Personally, in training and as well as training my other colleagues, I find that biportal surgery has a less steep learning curve, and they tend to be able to pick up the surgery faster and provide safety as well as effective surgery earlier than uniportal surgery. So in my mind, there's an endoscopic ladder of competence progression model, and starting from the left-sided L4-5 for UBE, and then subsequently maybe they can, once they're familiar doing extraforaminal and right-sided UBE, and then subsequently go to the cervical first before thoracic as well as fusion. So I just have a discussion on the approaches to lumbar spine. UBE, like uniportal surgery, can approach through the interlaminar, contralateral, and far lateral approach. Today, Professor Zhang has already shown us how to do the interlaminar as well as contralateral approach. There's another far lateral approach which is quite similar to what Professor Koichi Sayo showed us just now, which is transforaminal approach. And there's also an endoscopic fusion, which is have a standard U leaf as well as a recently popular XT leaf, which put in larger cages. There's also versatility beyond the approach itself. For example, you can do an interlaminar approach and then a contralateral approach, and then go further, decompress the central and lateral recess, and then go even further to decompress the foramen on the contralateral side. You can also use a 30-degree scope and also decompress more using curved osteotome, for example, to ipsilateral side foramen. So I just show some examples. This is an interlaminar approach. I'm going to write it up in a textbook, and it's going to be published. There is a two slight difference in UBE and best skin incision in my own reading and opinion. I've tried both of them. Basically, in the best system, that is a little bit closer to the midline, and the working viewing portal tend to be a little bit closer compared to UBE, which is the incisions is made in the medial pedicle line. This is a sequence of how we do the fluoroscopy to confirm the landmark midline is marked medial pedicle line. You mark this level, and then we put in the port, viewing port, as well as the working portal. We triangulate nicely, and then we put in the scope subsequently. I tend to also, before I drill, do another X-ray to confirm the level, and then I drill and mark it so that I can take that as a reference in my endoscopic procedure. I think the biportal surgery, being a floating technique, allow us to use multiple portals as well, as long as we are familiar with the principle. First, if we put a viewing portal, we try to minimize bone obstruction, the viewing portal, so that we do not need to get rid of a lot of bone before we get into the interlaminar space. Second, we need a 2.5 to 3 cm gap between the viewing and working portal so that there won't be a congestion of scope, or what the Korean like to call it, fighting between the working instrument as well as the scope. We also can minimize the bone resection required for when we put the working portal closer to the surgical sites, for example, caudal laminar or the SAP, so that we can facilitate an infusion in line with this level so that we can facilitate the process of surgery. Having the working portal close, being parallel, also allow us to have a favorable working angle for instruments. This is a video of our discectomy, interlaminar discectomy. I hope it's playing well for you. Basically, a 60-year-old with severe pain in the left leg radiating to the left posterior thigh calf as well as the sole. And you can see he has an L5S1 left-sided paracentral disc. The portals are made, and then we can basically, for me, we can do either ligamentum preservation as well as full ligamentum resection surgery. In this case, I removed the ligamentum flavum. There are people, nowadays I tend to just remove partially the ligamentum flavum or split it, which is similar to uniportal surgery. And you can see there's a pretty good view of the interlaminar space and a good bleeding control, exposing the traversing nerve root. And at this level, you can now engage your assistants to retract the nerve root, expose the disc using an Indian knife, and you can basically remove the disc effectively before you perform hemostasis and closure. And and then next in the next ladder, we talk about stenosis decompression. We start making a spinal laminar junction base cam. This is a video that you have seen before. After we mark the level, we perform making the base cam. We visualize the spinal laminar junction, and then subsequently mark using an X-ray, and then I drill the level. Perform a Cathalact laminotomy, essentially going upwards and laterally exposing the midline cleavage, which is between the two flavum. There will be some bleeding superficial vessel, which you can use the bones or other companies' radiofrequency ablation to stop the bleeding. And then you define the caudal laminar first. I tend to do that. Also, as I mentioned earlier on, I trim this spinous process of the caudal laminar so that I create more working space, lift up the ligamentum flavum, the superficial and deep layer, I separate it out. This is something that we can do in biportal, and uniportal is more challenging. In uniportal, if I do this, I have to really drill the superficial flavum off and use basically a forceps and pull off the superficial flavum. In biportal, we just use curette and you can separate them. Now we can see that we are going contralateral side. I tend to use the osteotome, and Dr. Zhang Wei showed us that he used the Kerrison very well using this approach. And then we do the Cathalact laminotomy, contralateral side. You can use a drill. I use the drill quite often here, and in this case, I just use the osteotome. I think it's just personal preference, and I see whichever is more convenient, and I do that. Subsequently, we will do the ipsilateral flavectomy followed by contralateral flavectomy. I mean, when I do uniportal, I tend to do contralateral first, so that I can visualize better when I do the ipsilateral flavectomy. I think there's no difference between the two techniques. I think you can do pretty well doing either way. But in biportal, I tend to do the ipsilateral first, so I create some space before I remove the contralateral ligamentum flavum. You can use the forceps for the contralateral ligamentum flavum. I think that is quite a safe approach. Now you can see the traversing and exiting nerve root. There tends to be some bleeding around the discal area, I think, and axillary area. So which Dr. DJ Choice call a crossing vein over this area. It's a good anatomical landmark for distal, enough distal resection. Now we remove the caudal laminar, top part of caudal laminar, and then you can see this is the beauty of biportal surgery. You can use a forceps and easily remove the contralateral flavum by plugging them out. And it's very safe because you are above the plane of dura. If you want to be extra careful, you can use upward pointing for forceps, and it's even safer. And then finally, you can use osteotome, you can use Kerrison, you can use a curved Kerrison like Dr. Zhang Wei showed for contralateral SAP resection. I use osteotome for that, and then we remove the contralateral ligamentum flavum. Okay. Sorry for a lengthy video. I think two level I'm not going to show is pretty similar. The only difference is that you need to make another portal. The working portal becomes the viewing portal. And then the far lateral approach is this is the L45 left side. Basically, we call it P+2 or P+3. So lateral aspect of pedicle, and then you go to the +2 or 3 cm of the pedicle to depending on size of the patient, and then you can get to the far lateral. Eventually, the view looks somewhat similar to transforaminal or steep angle approach to a transforaminal uniportal approach. This is how we do it. So basically, I think in the paracentral or far lateral approach, there tends to be a bit more soft tissue than the interlaminar approach. Muscles are more robust in this area, and we need to be very careful not to go underneath the TP and breach the transverse membrane, transverse process membrane, which can lead to our saline fluid in the peritoneum. So we need to be very careful. There's also another being careful thing about this is the radicular artery is close by. It's a floating technique. I tend to retract them away and then resect the SAP. As you can see, we are digging under the ventral lateral aspect of the SAP. You can use the osteotome to get rid of it. You can also use a drill. Really no difference between how you do it. Essentially, after you identify you may see the exiting nerve root after that, or you may not, depending on how tight is that foramen. I like Biportal when there's a lot of bone that you need to resect, because we can just use osteotome and knock them out, rather than in Uniportal I have to really drill for quite a prolonged period of time. But essentially, it's whichever technique that you feel best for your patient. Essentially, it is what it is, and then after you identify the exiting nerve root, which you can see I'm pushing it out, as a floating technique, so you tend to relax the nerve root retraction a bit. You are not using a working tube directly on the nerve root, pushing it away, causing potentially a dorsal root ganglion paresthesia. You push it away, and then you make a small incision and take out this blue dye. I still tend to use blue dye even when I do biportal surgery. I know this is what I've been doing in my uniportal transforaminal surgery. So after you make a discectomy for extraforaminal disc, then you can retrieve the disc pretty well. Yeah, as you can see here. For the interest of time, I will move on. I would skip this. This is basically showing a decompression instead of discectomy. And then I think Professor Zhang Wei showed a very nice contralateral approach. Just to show briefly, essentially, you can preserve the ipsilateral ligamentum flavum. You use a lower port, slightly lower portal, so you can get to easier to get to the foramen on the contralateral side. I think Professor Zhang Wei showed earlier on, he used a 30-degree scope. I use a 0-degree scope. The difference is not much, but if you use a 0-degree scope, then you tend to remove a little bit more bone, so that and whatever you have seen directly in front of you, you probably have decompressed already. So you can see that we are trying to get through the base of the spinous process of the capillary lamina, which in this case would be the L4, and then you can get to the contralateral side. Sorry for the lengthy video, and then there's this landmark that you can do. They tend to be a little bit, they tend to be this sharp corner marks the midline. Then you get the more contralateral laminotomy to the cranial attachment of the ligamentum flavum. The ligamentum flavum attached quite laterally towards the pedicle. So you got to use a curette, or you can use a kerosene to get rid of the ligamentum flavum. And now resecting the SAP, which is similar to my technique, but I am more expensive here. That means I'm going more lateral than what I did last time. And removing, using a curve or straight kerosene, the superior articular process. And you can see the blue dye. I still use blue dye and then mark this and perform a discectomy. In this case, I didn't need to expose the exiting nerve root or L4 contralaterally. There wasn't a huge disc to remove. I'm just doing final completion of some of the osteotomy, and then you can get to quite lateral aspect of the to decompress the foramen and extraforaminal region. For the interest of time, I'm moving on to the next slide. So I published that as a uniportal, interestingly, contralateral approach, but I used a similar strategy for biportal. The main difference is really how much bone work you think you need. If you really need to remove a lot of bone, I like, as I said before, biportal, so that I can use osteotome and quickly knock off those bones. And while in uniportal, I may have to do a little bit longer, but the results are similar. And finally, just a bit of the endoscopic fusion. I think this one will be covered by a lot of our colleagues. And then this positioning, we tend to make the incision I tend to make it horizontal on the pedicle. On the right side, we tend to be a bit lower so that the working port can be directly parallel to the end plate. I find that insertion of cage is easier. I published this in the as a inside or outside in technique as a Uniportal way of approach with Professor Hugh Song Kim. We label it Kim's point and Wu's point. I think basically if you move from medial to lateral, then in this study, when we use Uniportal technique, we find that from outside going in is faster than the inside going out, but clinical results are similar. So this basically showing basically our incisions and then the cage trial. You can see from biportal surgery that independent. The discectomy can be I use a working retractor. I do not be so dependent on my assistant. I do not have the fortunate opportunity of having similar assistant all the time. My assistants varies, and different resident may be scrubbing with me, so I tend to use a working retractor that's transparent so that I can retract the nerve root and prepare the disc. You can get pretty good visualization of the nerve root, the disc, and the end plate, which is pretty similar to what we can do with Uniportal, transfacetal resection approach. After that, you have to prepare adequately the disc. You can see, you can insert the cage using fluoroscopic as well as endoscopic guidance. And that's the cage, it's a PEEK cage, and you can see that it's inserted nicely in the central area of the intervertebral space. And then we put in the screws. Interestingly, I did both Uniportal and Biportal. Most of my patients, despite not having a drain, they are ambulatory the next day, and a lot of them discharged the next day afternoon. So, I mean, I do not have a huge series, but and the results are early. I find that it is quite, so far in a 1.5 year follow-up, they're doing pretty well. Finally, I will skip this for the interest of time. You can do bilateral, I mean, you can do more than one level fusion, and these are various papers that we wrote up for endoscopic fusion. In conclusions, UBE is versatile and can be applied to most clinical situations for degenerative lumbar spinal conditions. Basic principle must be applied: creation of submuscular space, creation of subosseous space, followed by bony decompression, flavum resection, hemostasis, and then check for neural decompression. There are new approaches, and it's very exciting. I think Dr. Jiang shows us the third portal, the opposite side. You can make a quarterback portals to flow better, or you want to do a dural repair or annular repair, annular stitching to close the disc. Or you can use another port for XT-leaf to put in larger cages. I think what a biportal does is really versatility. You can have more ports, you can have like some of the discussants say before, robots coming in, more assistants coming in to help you, and it's all possible. Thank you very much. Sorry, may I take more than the time that I required.
Thank you, Dr. Pang Wu, for this wonderful presentation. So if there are questions, please record it, and we will discuss this later because we are a little bit short in time. So we will send the questions to the speakers, and please put your email with your question so that the speaker can answer to you personally. And so let's come now to the next speaker, Dr. Toi Ngoc Nguyen from Ho Chi Minh City University Medical Center in Vietnam. So his topic is UB contralateral sublaminar approach for L5S1 foraminal stenosis. Welcome.
Hello, everyone. Can you hear me?
Yes, we can.
Okay,
can proceed.
Can you see me out my PPT?
Yes, we can see your slides and yourself.
Okay. Hello, everyone. I'm Dr. Nguyen Ngoc Toi. I'm from Ho Chi Minh City University Medical Center in Vietnam. And I'm very happy to be here and share my experience in UB contralateral sublaminar approach for L5S1 foraminal stenosis. And as you know that nowadays, one of the most thing we must confront in lumbar spine surgery is the fell back surgery syndrome. And there are many reasons, many etiology of this syndrome. And one of them is foraminal stenosis. The foraminal stenosis may be very difficult in diagnosis and very difficult in treatment. And in a research of Dr. Janice, the foraminal stenosis have about 8 to 11%. That's indication for surgical procedure. So the first thing we should know what is foraminal. The foraminal is a tunnel where the